Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I am with Alex. How are you doing today?
Oh, always a privilege and a pleasure to spend some time with you again, Dennis. Thanks so much for the invitation, my friend.
Awesome. So the reason why I asked you on is just your experience reviewing papers, and what I would like to do is, we have a paper here to review, but I would like to try and start doing this a little more frequently. And since I can't read a research paper without Googling 90% of it, I figured I would get a pro on.
Your trust may be overextended there a bit, but it has been an interesting career trajectory for me to start as a EMT on an ambulance in a civilian practice setting, and then go on to become a hospital-based trauma surgery PA, and then after that start to support some of you guys who actually do the important work out in the field and really kind of understand the nuances between clinical medicine, which is hospital-based and very CPG directed, and then operational medicine, which is just getting stuff done when you're in bad places, perhaps working with guys doing bad things to bad people, and just doing the best that you can. And so really not trying to throw any shade on anybody here, but just trying to help provide some insight. And so this is a first attempt, I think, at a paper that might be clinically relevant. It may not be clinically relevant. I'm definitely hoping that some of your listeners will give us some feedback. Is there a good way that they can recommend papers to us?
Yeah, absolutely. You can just send me email, dennis@prolongedfieldcare.org, and we'll give it a look.
Yeah, right on. And we're definitely interested in relatively recent papers that have good clinical applicability to the operational environment, because Dennis came up with this idea, and it was like, hey, all you docs and PAs, you have your great papers, but I don't care if it only applies to the hospital. I actually care if it applies to the field. So I think that's kind of our idea with this, right?
Yeah, absolutely. And I've run into many very well-meaning medics who have, come at me on the top rope, and it's like, I have read this paper, and what we've done is wrong. We to stop doing fill in the blank. And you ask them, and I'll look at the paper, and you have to be like, hey, bro, like, they use 7 people, and I don't really think this necessarily applies because of these reasons. And they're like, crap, I just read the conclusion. Like, like, this needs to be, we need to, as a community, kind of get used to reading papers. Believe it or not, you're going to have to read the entire freaking thing in order to get something out of it. And at the end of it, we have to, I think critically about, well, where does this apply? Because some incredibly nerdy papers, they can have next to no application, or they can be like the thing that starts like a complete change of practice by telling you, like, hey, and I think this paper we're getting ready to review, I don't know necessarily that I'm going to change lots, but it's definitely going to give me food for thought about how do I pick my patients when it comes to, calcium, TXA, other things like that.
Yeah. And I might come at it from just, my own perspective as not a medic anymore, but more of a PA doc now, which is, you were saying in the community, get used to reading papers. And I hear from a lot of medics, and they say, bro, I'd love to, but I don't have the time because I'm too busy. And that is totally fair. And that is very relevant. And I would say that then you should be leaning on your doc or PA, because in my humble opinion, the whole job of a battalion, brigade, PA is to support their medics, or especially like if you're at the BSB, like you work for the medics work for the team works for the GFC. And so this paper that we're going to be reviewing, you should be able to get access to it through your doc or PA, who should be able to get access to the Journal of Trauma and Acute Care Surgery through their privileges at their local military treatment facility. Because, fun insight, all of those military treatment facilities have a medical librarian who manages access to all of these fantastic medical journals out there. And, as a case in point, so the article that you picked today from the Journal of Trauma, I think last time I checked, an annual subscription to the Journal of Trauma is like $800 a year. I can't afford that, right? So I just go to my hospital librarian and she gets it for me. But rely on your doc and your PA, right there, sitting in a cushy office, working Monday through Friday, 9 to 5, while you're out doing the important work out in the field, supporting the team. So have them work for you.
Yeah, no, absolutely. Just asking them questions. What the hell do you want me to do? Right? Because everybody will come up with a good idea fairy. But if you don't, if you don't push back, if you don't ask questions, they're going to just kind of assume you know the answer, like follow the algorithm. And sometimes there's questions with that.
Yeah, so this paper in particular we picked because it was so important that it was selected as the EAST conference, and that's Eastern Association of Surgery for Trauma, podium paper of the year at their conference. And just for a little bit of insight, starting at the top, the American Medical Association supervises all physicians in the U.S. and through their guidance, regulations, license, certification, and then state licensure. The American College of Surgeons manages all surgeons. But then under there, the guys that I start to really care about is AAST, which is the American Association of Surgery for Trauma. That's a fun group of folks. That's a great conference to go to if you ever can. And then underneath that is EAST, again, Eastern Association of Surgery for Trauma, and they happen to be more East Coast, coincidentally. They really focus a lot more on the science, and they have, EAST has a whole bunch of great CPGs that are really good to reference, and they're more heavily evidence-based. And then over here on the left side of the country, where I am, there's WTA, or the Western Trauma Association, and they always have a great conference somewhere in winter that happens to be at a great ski resort. Hint, hint, also a fantastic conference. So that's kind of the lay of the land of where you will find your trauma critical care surgeons getting together to review evidence. And again, so at the Eastern conference this year, they said that this paper presentation was one of the most important ones presented and was great basic science. And so the title is Direct Red Blood Cell Effect on Thrombosis is Dependent on the Interaction of Tissue Factor and Calcium in Membrane Phosphatidylserine. Did I say that right? You've practiced that more than I have.
I sure as hell have. Phosphatidylserine.
Phosphatidylserine. Thanks, Dennis. So this is a whole host of authors. First author is Dr. Adam Price. And so we're going to consider this essentially a benchtop study in terms of what level of evidence this is. There's a bunch of different scales out there. I think I sent you a few of them ahead of time. Depending on which level of evidence scale you look at, you could grade this differently. What would you call this one?
To be honest, I have no idea.
Yeah, that's fair. So I kind of view most benchtop or animal studies as like level 4 evidence. Level 5 is garbage. Level 5 is absolutely the lowest. It's expert opinion. I'm going to throw a little bit of shade here. That's what most of the TC3 guidelines are, is expert opinion. But to be fair, they will be the first ones to say it has to be expert opinion because there isn't enough evidence out there in the combat environment to create evidence-based guidelines. right? So they're the ones who really made me pull my head out of my posterior and say, yeah, that's totally fair. The TC3 guidelines are probably level 5 garbage, expert opinion, because that's the best we've got for now. So again, no shade, but just context. Level 1 evidence is a meta-analysis and systematic review of multiple multi-center randomized placebo-controlled trials. Though that's money right there. We're never going to get that in the pre-hospital environment in combat medicine. And then, depending on the scale you use, probably level 2 evidence is prospective studies, especially in a multi-center. And level 3 is those retrospective studies where you just pull some chart data after the fact and kind of crunch it together. So I think this is probably a level 4 evidence. Does that seem reasonable to you? Yeah, 100%. And so kind of their background that they lead off with this paper, which, if you want to read along with us, Journal of Trauma and Acute Care Surgery, July 2024, page 57 to 64. And they were kind of scratching their head and saying there is an increasing amount of evidence looking to red blood cells actually being a part of the thrombosis and post-transfusion hypercoagulability, which, as we were talking about before the recording, that's news to me. I just thought that platelets were part of the most important part of the thrombosis chain. And then we have definitely seen in some surveillance of serum in post-trauma care that there's this increase in serum tissue factor. So these authors were hypothesizing that the phosphatidylserine is a prothrombotic phospholipid that's inside RBC cells, and they were curious about how that particular prothrombotic agent may exacerbate the inflammatory and thrombotic pathway, especially in your post-trauma patient, and how it could contribute to some of those serious thrombotic cascades. And I think you were talking about it before. What would you be concerned about in a post-trauma patient in terms of clotting?
I mean, my first problem with some kind of combat trauma is making a clot. Like everything is focused on stopping the bleeding, patching them up, whether that be I put enough pressure on it and crush that vessel down to where it stops bleeding, or God willing, like he makes a clot and I still win. So essentially all the protocols, the algorithms are about making clots. I think when I'm pushed towards something like that, it always gives me a second of pause of like, there's another side of this coin, and it probably isn't good to just solely focus on making clots. Like the body naturally controls this, and I found that if you let the body do what it wants to do, generally the patients seem to do better longer.
Yeah, it's such a fine balancing act that the body has to make clots after trauma, and then it immediately has to start breaking them down. And of course, that's, as we all know, where TXA comes in. And so these guys were trying to, scratch the itch of exploring that a little bit further. And there's actually a great quote that I failed to find ahead of time talking about essentially, as long as your patient can survive the inflammatory autoimmune response from illness, they should be able to survive. And that's, in many times, a lot of our challenge in the ICU, managing these people, 24, 72 hours after injury, when, again, medics do phenomenal work in the field, and our ER colleagues spend an hour or so stabilizing these folks and then ship them to us for long-term management as the milieu of inflammatory secondary and tertiary responses. So how do you study this? I'm not smart enough, but these guys had a pretty elegant method of trying to answer this question. So getting an IRB or institution review board, which is a prerequisite. You've got to do that before doing research. They got approval to grab 10 blood samples that were from normal healthy volunteers who were already there to donate blood, as well as 4 samples that were extra blood from trauma patients who were already getting blood drawn for their rainbow panel. Those blood samples were then spun down and separated. So the 3 different sample arms were experimenting on a small volume of whole blood, RBCs only, and platelet-rich plasma. And I don't know if you saw, but I really appreciated that what they did to make this study more homogeneous is they actually just took the whole blood, the RBCs, and the platelets from all of those 14 different, I'll call them donors, but they're not really donors and they're not subjects. And then they just poured it all together to just make essentially one data point. So in some ways that's easier for analysis, but it also then lacks granularity. What do you think about that?
Yeah, I gotta be honest, that didn't really make lots of sense to me, because you're looking at, healthy people, sick people. I don't really understand why you would want to mix sick people with healthy people's samples, to be able to find out kind of the context of what the hell is going on.
Well, that's fair. Yeah. And I think we'll get to that a little bit later in our analysis in terms of internal and external validity. That you're 100% right. The mixing of samples between healthy and trauma patients may have clouded some conclusions. But they had those 3 different samples, and then they basically threw a bunch of different stuff at them and then ran them through a tag to see how well they clotted or didn't clot. So with all 3 of those experiments, they put that in the face of arachidonic acid, ADP, collagen, calcium, which we all care about, as well as tissue factor. And then the other one is the red blood cells were actually pre-treated with annexin 5, which is a blocking agent to the phosphatidylserine, to see if they could isolate the effects of the phosphatidylserine a little bit better. So really an elegant study, very, very small sample size, very small data set on a benchtop model, which, the fancy term that they're using for this is in vitro. They also had a really cool platform where they were testing it. I don't know if you read through that, but I thought it was super cool. They had a microcirculatory, it looked like just plastic model that they infiltrated with cultured pulmonary epithelial cells. So basically in this lab, they made what looked a lot like pulmonary circulation from actual cells and then ran these different fluids through there until under direct visualization, they saw a lack of flow. I've never seen that before. I'm assuming you guys probably don't have that level of research equipment at the schoolhouse.
Yeah. No, I have not made my own capillary beds, on a bench top anyway, but that was pretty cool.
And what was your takeaway as far as the results? How did you interpret what they saw from their different data sets?
I got data set wise, I wasn't super surprised, and this is coming from somebody who doesn't have probably the brain power to blow his nose, but when they ran it, they added the calcium, they added the tissue factor, both separately and ultimately combined. They had them. It found that there was increases when you had calcium, which I think makes sense. Calcium is part of the clotting cascade. It's going to be a procoagulant. Tissue factor, when there is trauma, that tissue factor gets released. The entire part of that, it's a signal that there's been trauma. and part of that inflammatory process is the clotting cascade. So that made sense. And I don't think it was a giant surprise when you combine those two things together, got even more of a response.
Yeah, and we probably should have said in the background, it's pretty cool to me. This is new about just kind of that the phosphatidyl, phosphatidylserine is actually on the inside of the phospholipid layer of the red blood cells, but it can be expressed on the outside and therefore trigger a lot of the thrombosis in the setting of tissue factor, which is upregulated in trauma. So it's, again, we're really talking like secondary, third order effects here. And so their conclusion is basically what you said based on their data set, which is that you tend to see a significant increase in red blood cell aggregation in particular in the setting of tissue factor and calcium. And they think, interpreting their data, this is probably from the phosphatidylserine, based on how they did this experiment, because the highest amount of occlusion was seen in the isolated RBC cells. There was less occlusion in the whole blood, probably because it was just more dilute, right? Because there just weren't as many RBCs, and there was very, very little occlusion in the plasma-rich protein. So kind of by a process of elimination, the common pathway there associated with occlusion is the high density of RBCs, which was reversible with their agent that they induced, the annexin 5. So they are very reasonable in saying that this is a incredibly small sample size and a benchtop model. It's absolutely not ready for prime time, but it certainly does ask a lot of reasonable and appropriate questions. In terms of internal validity, we like to ask this when we're doing systematic analyses of papers, which is, internal validity is, do we think that the results of this paper would be consistent if we looked at a wider data set of similar data collections? So, like if we just collected exactly the same samples and we redid the study, would the data be repeatable? I'd say probably yes. But the more important thing that we really should care about, and a lot of us don't when we're looking at these types of papers, is external validity. And external validity, is, I'm sure you know, means, great, good for you. You looked at this one small data set. Does that apply to absolutely everyone in the whole world? And I think we really swing and a miss with external validity when we try to apply civilian trauma data to the combat environment, both because the tissue burden is dramatically different, as we talked about earlier. Civilians, they get either hit by a car or shot with a low velocity, usually target ammo is what I see from the gangbangers who can't afford good hollow point, or they get stabbed. That's a totally different tissue injury burden from combat, where you've often got large tissue burdens from blast injury. And also the demographics are different, right? So overwhelmingly, in the civilian model, you see less physically fit, older folks that are disproportionately male, but there is a pretty high female proportion of trauma patients. That is vastly different demographics from the combat environment, when you see overwhelmingly young, healthy men who suffer blast injuries. And so just kind of trying to apply those data sets from one to the other blindly really means you're failing at that external validity. So this being a benchtop model, I don't know that I could apply this to humans yet. What do you think?
I mean, I guess I don't understand why not.
Mm.
And I think it's a factor of scale, essentially. Yes, your war wounds are going to be probably more dramatic, versus maybe civilian. But I'm willing to bet the same process is happening. It's a kind of a factor of how bad is bad. I think, that should a thought going forward with what we recommend to our medics, regardless of where they're working, is, how is this going to apply to the patients that they're going to see more than likely?
Yeah, well, and your question for me is always a good one, which is, why should I care about this paper if I'm the practicing medic in the field? And for this paper, I'm not sure that I have a good answer for that. What's your takeaway for the guy who's getting ready to deploy next week to fill in the blank? Does he need to change his kit or change his practice or approach to a trauma lane with this?
Not necessarily. I don't think it really has a giant factor when it comes to your basic March algorithm. You're still going to want to stop the bleeding. You're still going to want them to breathe. We're going to have to make sure that the chest is moving up and down. They're still going to get cold. You're going to have to cover them up. We're going to want some kind of access points. That's not going to change at all. But for me, it started to make me think like maybe the TXA and the calcium isn't for everybody.
Oh, be still my heart. You have no idea how much joy that brings me to hear you say that we need to think critically about our critically ill patients.
Yeah. Slow your horse. I do have an algorithm, but I guess from my point of view, when it comes to TXA, calcium, just because somebody gets a bloody nose, one, it doesn't mean they need blood, and it definitely doesn't mean they need TXA and calcium. So I think we need to pick our patients based on, and that need has to be assessed.
Yeah. And I mean, that really harkens to something that took me a really long time to appreciate and understand, which is if you are in a operational environment where tactics are more important than clinical medicine, then just do your algorithm, move on, suppress the threat, move to a safe environment. But if you're just chilling somewhere in like a safe house, probably following a checklist, is not what's going to be best for your patient, right? I mean, that's not what I do in the ICU. We sit down and I like to chin scratch for quite a while, for far too long for a lot of our patients, right? But we take a really analytic approach to what's the underlying pathophysiology and what interventions are going to have more benefit than a harm. And if you are in a place in an operational environment where you have the time to do that, that's probably what's going to be best for your patient. And you are 100% right that we have certainly started to see signals in the data through the joint trauma system that TXA absolutely has harms. There are times when it is appropriate to just slam 2 grams and move on. If you're, a ranger medic in the back of a black dark 47 taking evasive maneuvers, dude, just checklist it and move on, right? You got more important things to deal with, right? I'm not gonna disparage you for slamming 2 grams whether your patient needs it or not, because you got more important things to do. But we tend to see this very significant creep from operational medicine, which is done mostly for the benefit of tactics, to clinical medicine. And TXA has certainly been one of them where everybody gets it and not everybody needs it. The other one that a lot of guys will hear me talk about is INVANS, right? INVANS is a great tactical medicine. It's small weight and cube. It's once every 24 hours. It has broad coverage. Do you think everybody needs INVANS?
Not everybody, and absolutely not if you're talking about burns. But I'm far less scared of a gram of INVANS than I am of the gram of calcium on the guy that's got a bullet hole through his hand.
Yeah. And so to scratch that itch, let me ask you the critical care question. So, bullet hole through the hand. Why would you think that a gram of calcium might not be? I don't want to say indicated, but might not be as beneficial? Because these are all shades of gray.
Bullet hole through the hand. I have hemorrhage. I can get hemorrhage control. I promise you. He might not like it, but I can get hemorrhage control. And kind of the same reason, I probably wouldn't bother pushing TXA on this guy. I have hemorrhage control. Like, you push it, it's going to circulate the remainder of their body and not get to the wound where I actually want it. It's not human fix-a-flat. Like it's an active hormone or chemical that's doing stuff to their body that I don't have the assessment tools to tell me if things are going wrong. I can't tell you, hey, he's making clots because I've analyzed whatever it is that you guys do analyze that say he's throwing clots around. And I know I can do that pretty damn quick as far as hemorrhage control on an injury like that. I would honestly, I would be expecting the guy to his left or right to do the hemorrhage control, and I'd be more thinking about pain control or getting him off the X or somewhere safe so I can look at it quick. Then we're going to move on within 5 minutes. I promise. But I think the algorithm of have trauma 2 grams on everybody, and if he has any kind of inkling that he might need blood, which of course every trauma patient needs at least 1 unit of blood, just based on all the lanes that I've ever watched, you're going to follow that up with a gram of calcium because that's what people say. I don't think we can afford to do that.
Yeah, and I think if I remember, one of the questions you texted me before we recorded this was, does this article say that we shouldn't be pushing calcium on trauma patients? What do you think?
I don't think was the intended. I think it was more of like an anatomic or physiologic discovery. Like, hey, turns out RBCs are active too, which to me, and again, I have like an entire year of medical training and I've read a book. I kind of understood that blood is a living tissue and the activation of this thing is incredibly complicated and every component has more than one use. Like I just knew that. I don't know what they all are, but I know that all of it's active. It didn't really surprise me that much that RBCs would drift to the site of injury and start coming together, and then I have my thrombin matrix kind of patching that in. I wasn't super surprised about it, but I don't think that they meant it to be any kind of change in medical procedure. I think they were just more of informing like a physiologic happening.
Yeah. This is what we would definitely call basic science, which is hypothesis generating. So follow-on studies maybe in an animal model, and then follow-on studies potentially in a human model. And in terms of the time of cells, which you brought up, we should have mentioned that they actually did multiple different time point testing. So they did red blood cells that were, I want to say 2 days old, 20 something days old, and up to 42 days old. And I thought that was a really cool data point that they managed, because they said, gosh, is this effect going to look different on fresh whole blood, which we would potentially run into, or a cold stored whole blood? And in this data set, they actually didn't see a difference across the spectrum there, which is really good to know.
Yeah. Just because I happened to pull up the graph, it looked like day 14 and day 21, so 2 weeks, 3 weeks old, it looked like it was slightly more active. But I mean, that's the blood you're going to get. Day 0, get it. And whoever you're getting that cold stored blood had drawn it, a week or so ago, shipped it over to wherever you are. Of course, there's paperwork, so that's going to take a few days. At best, you're probably looking at blood that's a week and a half, maybe old, I think.
Yeah. Yeah, the I think if I remember, we're switching over to the additive that's going to allow blood to be up to 35 days old instead of just the 21. But I mean, on all my austere deployments, we hope to get blood once a week, and usually most of our blood's about to expire every 7 days. So that is not insignificant. But I mean, your point is well taken, which is the people that you really want alongside you as you're managing a either hypercoagulable, which is what this paper looked at, or a hypocoagulable trauma patient. The person I feel most comfortable having next to me, either in the resuscitation bay or up in the ICU or the OR, is a trauma surgeon. And when you talk to them, they say trauma surgery and managing critically ill trauma patients is really easy after you go to 4 years of med school, 5 years of a surgical residency, and 2 years of a trauma critical care fellowship. After that, it's not that hard. And so when you and I, with not that much training, say that, oh yeah, we can handle a critically ill patient for 72 hours, there's a fair amount of hubris involved with that. And I think the nuance of this paper, when you really start to deep dive on the pathophys, was a great reminder for me about how complicated this is. Because I guarantee if I review this with one of my surgeons, they're going to go, oh yeah, I knew that already. I didn't.
No, you didn't. They just found that out right now.
Yeah, 100%. But, so managing critically ill patients is really difficult. And even if you're doing it full time, it's still pretty terrifying to get stuck out alone and afraid with limited resources and to try and manage these people on your own. So, I think this paper would be a great reminder that, the more MPT you can do, in a like setting to what you are concerned about seeing, the more well prepared you will be, but you will never be fully prepared.
Yeah. I think the great thing about being in like an ICU is you get to see all of the different signs, the different variables that somebody else is putting into the equation of what do I do next with this patient.
Mm-hmm.
Now, of the, let's say like the 12 things or maybe even more things that they're actually measuring and adjusting fire with, I can probably assess maybe 4, but you also get to see like how these other things that I can't necessarily directly measure, well, how does it affect this other thing? What other tools do I have that can warn me that this other thing is happening? And I've gotten a larger appreciation for things that before I would just say, that's nerd shit. That's not even, that's not coming in the bag. That's not even getting on the pallet. Like, just leave it back for inventory. Like an iStat. You're a normal trauma patient, hemorrhage control, get them some blood, get them on an evac. Yeah, it's probably not appropriate to try and chase them around and get a blood sample so you can have some numbers. But when you're throwing in prolonged field care, you're throwing in electrolyte imbalances. Now he's on a vent. Like, things start adding up, and it turns out like that pulse ox that you stuck on his finger, it isn't like actually super accurate, and sometimes it fails. And do you have something else that you can lean on that can be hopefully more accurate and tell you, kind of essentially check the validity of your other monitors? Does that make sense?
Oh yeah, 100%. Yeah, this is actually just my last week up in the ICU. I alternate between ICU and trauma surgery. And yeah, we had a few critically ill patients where we were doing exactly what you just said, trying to get the constellation of different diagnostic data to make sense clinically. And then of course there's always the classic thing, which is if you don't like the data input, just ignore it or try and, explain it away. And
just
which is terrifying. Yeah, 100% terrifying. But even with that, right? We in my regional trauma center don't have a tag, which is what this study, one of the methods that they use to measure this. We're certainly not using the tag in the far forward environment. I'm just thinking real quick. In all of our AOs, is there even a theater hospital? No, there's not even a theater hospital that's got tag, let alone actually measuring phosphatidylserine. So we're really trying to manage critically ill patients with not with tools but with knowledge. And this paper was just a great reminder about how nuanced clotting is, and that there are true harms that can come from interventions. And so when we get a little nerdy and we talk risk versus benefit, that's always a ratio, right? And you expect that the benefit for an intervention for your patient is going to be greater than the potential harm. And to your point, there are some interventions. Calcium was listed here. TXA has been talked about quite a bit, in which there are certain patients in which there is zero benefit. And I'm sure you've seen that in the past. Again, in our civilian practice, we have seen patients who have had very, very, very small injuries that were completely physiologically stable, that were not expected to receive any intervention in the ER when they arrived, and they received TXA. What are the odds that TXA administration took them from the bucket of, oh my God, they're going to die before they get to us, to they're going to live and go home? None, right? So there is zero chance of benefit, which means that if you try and balance benefit and risk, however small the risk is from those interventions, it is greater than the benefit, because the benefit's zero. And certainly there are some indications from this paper that potentially some of the interventions we're doing now may have the potential to do more harm than we fully appreciate. I certainly won't change practice. I am still a huge calcium advocate, and I would very much encourage people to read Dr. Linda Benavides et al., her awesome article that was in the Journal of Trauma, 4 or 5 years ago, when she was at an FST in Afghanistan getting after it, because she is just an awesome trauma surgeon. And they did some retrospective data collection on their patients, which again is like level 3 evidence. And what they were able to do is, using their iStat, yes, iStats are awesome, they were able to get some point of care calciums on these really messed up trauma patients arriving at their FST. And what they found is that before they got citrated blood, before they got any interventions, all of them, 100%, were profoundly hypocalcemic. And because that is a rate limiting factor on the clotting cascade, they were able to essentially tank up those guys with calcium and reinitiate their clotting cascade. So probably the benefit is greater than the risk in calcium. Again, this paper doesn't change that. But it is really fascinating from a basic science level to know that there's all these other things that affect that terrible, terrible chart. Phosphatidylserine is internal to the phosphid, or the lipid layer of RBCs, but it gets expressed externally in the face of tissue factor after trauma. Like, that's stuff that I'm not talking about every day in the ICU. Are you covering that at the schoolhouse at that level of pathophys?
No. I mean, I had to Google it and then let Google tell me how to pronounce it. So
yeah. So this is a good learning experience for all of us, and this is a great reminder that you should be sitting down with your PA or doc and telling them that they should be understanding and reading this stuff. They should be reading this stuff. They should be reading this stuff, and they should be summarizing it for you and giving you the bullet points, because you're too busy to read this stuff if you are getting after it as a good team medic.
Yeah, absolutely. And I think just kind of the humility of, just because you memorized IC guidelines, because you've memorized what the CPG says, I would not say that you have it all figured out. There is going to be more things that come into play for your patient specific scenario. And if you don't know kind of the left and right, when is the right time to do this intervention, like you mentioned, just good clinical decision making, it's going to lead you astray because they wrote all of those guidelines. Each one of those authors had a patient in mind when they wrote it, and they wrote it for that patient. That patient might not match your patient.
Yeah, I think that's absolutely true. Well, I think that's about all I got. I'm going to be very curious to hear from your listeners on if this is helpful, and I think what we could do better going forward, because this is a really exciting project, and definitely want to get some feedback from the community. Folks can always hit me up on Signal. If you're in the community, you know my phone number. And what else do you got for us, man?
Yeah, I mean, kind of from this, so as a devout advocate on calcium, do you push it on everybody?
Yeah. Oh, yeah. Yeah. 100%. I think calcium is way more important than TXA. And actually, there are a number of very influential senior trauma surgeons within the U.S. that view TXA as poison. And especially to your point, if you have definitive hemorrhage control, TXA is providing no benefit, because especially if you put a tourniquet on the bleedy bits, then the TXA that you circulated is not getting past the tourniquet. And so like you are spitting upwind there, my friend. But as far as calcium, I pushed really hard, and we got calcium implemented on our massive transfusion protocol in our hospital. I strongly agree with Ricky Ditzel that there's probably a role for dry hemorrhage resuscitation. So if you do not have access to blood, likely calcium alone has the potential to improve your patient benefit. Again, because calcium is one of the first components of the clotting cascade that gets fully utilized, and then the clotting cascade stops, and being able to re-up that tank and then let the clotting cascade continue in the early hemorrhage resuscitation and trauma resuscitation is super important. Trying to not overshoot that clotting cascade with exogenous either inflammatory cytokines or exogenous chemicals like TXA is super hard to do, and no one in trauma surgery is perfect at finding just the right amount of clotting, but not too much. But I certainly have a lot more trust and respect for calcium and the clotting cascade than I do for TXA, and definitely encourage its liberal use. It's good in a martini too.
Yeah. So I guess my question is almost way too broad. So you mentioned massive transfusion protocol. That patient drastically different than I've got a hole through my hand, and I'm more complaining about I'll never play tennis again. Then, I'm not sure this guy will live the next 30 minutes.
Yeah.
The massive transfusion, the next hour is a giant question mark. And I found, if I'm getting decreased mental status, his blood pressure is low, we are 100% behind the power curve. I'm on your side. We're going to send calcium.
Mm-hmm.
Even if we haven't started the blood, I've sent calcium. And I've seen the positive effects of it, buying me time, getting access, and just crushing in blood.
Mm-hmm.
Likewise, I've seen patients that are not really hypotensive, but they maybe, I guess, you're class 2 shock, their heart rate's elevated, but their blood pressure seems to be fine. And I've watched people get calcium in that situation, and I've watched their heart rate tank. So, which is a big surprise to everybody.
Yeah, because calcium, as you know, fun little side note, is actually a vasoconstrictor. So you can actually use it as a dumb vasopressor, which again, the critical care surgeon or physicians love. So yeah, that's super weird. Might have been pushed in too fast. Hard to say.
Probably.
Fun side note, since we're doing literature and research and whatnot. So you very astutely cited the American Trauma College of Surgeons Advanced Trauma Life Support Class 2 shock, which has been adopted by the TC3 guidelines. Do you happen to know what body of research gave us the classes of shock, class 1, 2, and 3, and 4?
If I remember, a surgeon made it up, and he wrote it on like a napkin or something.
Yeah, man. Yeah, it was 2 orthopedic surgeons at a conference. Well, after a conference at a bar, and they wrote it down on the back of a bar napkin. You are 100% right.
Did they like chest bump afterwards?
For sure, man. Absolutely. And as a recovering orthopedic PA myself, one of my favorite jokes out there is, do you know the definition of a double-blinded medical study?
Both the people doing the study, performing the work, people analyzing the information have no idea about who got what.
Yeah, so the joke is the definition of a double-blinded medical study is 2 orthopedic surgeons looking at an EKG. Again, former orthopedic PA, love them. But the other great one is, how do you hide a $20 bill from an orthopedic surgeon? You put it in one of their academic journals.
Yeah.
But those 2 guys on the back of a bar napkin, they came up with what we now have as our shock categories, which is a little terrifying. That is, that's level 6 evidence, which we just made up here on the spot right now.
I guess what's funny about it, it stuck around, and it actually helps understand what the hell happens.
Yeah. Well, maybe it's that expert opinion because there's just not enough data.
Yeah, absolutely. So kind of wrapping up. So don't just push TXA on every bleeding person.
I don't know, if you're getting shot at, you should probably push TXA and then shoot back at the bad guys and then get to cover. It's kind of what I like to tell people, because that's, again, if you're in the unstable environment, follow your protocols, put lead in the bad guy, get to safe space. I don't know that I would take that from this article, but yeah.
Yeah, and wasn't the intent of the article, I think. But I would say, did you focus well enough on hemorrhage control? Because like, kind of a joke, but it's not human fix-a-flat. It works best in the capillary beds. It works best in low flow venous side. It works great for. If this person is bleeding to death, it's probably not from capillary bleeding. It's probably from a larger vessel that is gushing out blood. Would be my thought process. Focus on that, because your TXA isn't helping you. Get a good dressing on it, and if practically we don't have time, move out.
Yeah.
When we get safe, then worry about it.
Yeah. And please reassess your patient. So I just heard a heartbreaking story from one of our retired tier 1 surgeons who was over in Ukraine recently, and he had to assist with a bilateral lower extremity amputation on a soldier who had received indirect fire, had a very, very small laceration on one leg, and it was non-arterial, non-life-threatening bleeding, but they were in that tactical environment, and so a tourniquet was put on. That leg that had the small bleed ended up being uphill of their unaffected leg, and so there was some blood on the lower leg. So there was a tourniquet put on that leg with the blood sweep. And those folks stayed in the trenches for, I think it was about 12 hours until they could evac that patient, who did not have any life-threatening injury, had no arterial bleeding, could have had, to your point, very reasonable hemorrhage control with direct pressure. And instead, that guy now has a bilateral high above knee amputation.
Yeah.
That is a risk with no benefit from that application.
Yeah.
That's really sad.
It is. I mean, my first priority, did he live?
Yeah, fair.
You know, his family, I'm sure, would rather have to, help him move around than not have him, period.
Yeah. But he didn't need the tourniquet in the first place. Either of them.
He did not need it.
Yeah.
And so I asked my students, this week, what is the max period of time you can have a tourniquet on? They're like, 6 to 8 hours. That's a perfect book answer. What is the minimum amount of time you need to leave a tourniquet on? And they
1 second.
Stopped. Yeah. There essentially is no minimum period of time. As soon as you put it on, start thinking about, when can I take this off? If the tactics, the environment, the situation stops you because you're constantly on the move, or you're constantly under bombardment and yourself or others' lives are in question, all right, we'll leave it on. Hopefully you remember when you put it on. Okay. But if able, immediately start thinking about, what else can I do to take this tourniquet off. There is no minimum period of time.
Yeah. And there's been some pretty good retrospective studies in the civilian population. I don't have the references. I'll see if I can dig them up and maybe add them to the show notes. But basically anything under 2 hours in the civilian model is completely reversible for either ischemia or neuropraxia. Somewhere around 4 hours, depending on your demographics. You kind of got a 50-50 whether you're going to have long-term complications. And over 6 hours, according to the retrospective civilian data, it's probably better to just leave the tourniquet up, because the reperfusion injury is going to be too great for your critically ill patient, as well as potential ischemia that may just mean you're washing out dead infected tissue into the central circulation.
Absolutely.
But again, that's kind of that chin scratching that we do when we've got the white space, which you may or may not have, and it's a very, very different medicine depending on if you're in the tactical environment, or if you've got time to think about critically managing your critically ill patient.
Absolutely. So what was your big takeaway from this paper?
Managing trauma patients is hard. And I do it every day for work, and it's still terrifying.
Yeah, it absolutely is. And there's so many different variables, and the more you dig into things, the more you have to worry about. And so when you think you've gotten everything figured out, like, you just crested a false hill, man.
Ooh, that works two ways, because in mountaineering, the military summit, I believe, is the false summit, because that's usually a better observation point, so you're not on the top point. So that works two ways. I like that. I see what you did there.
Yep, I'm super deep. So cool.
Right on.
Well, thank you, Alex, for jumping in on this. I really appreciate you helping me walk through this paper.
Yeah, for sure. And I'm looking forward to feedback, because I think kind of your vision is that we will continue to look at we will look at scientific papers, but through a new approach that isn't well done, I think, in the community, which is how it applies to the operational environment. So we really want feedback in terms of what papers you think are out there and are interesting, and also how we can help look through them for you, the actively practicing medic who is too busy doing cool stuff with cool guys to nerd out like us old, out of shape dudes who sit at a desk.
Ouch. All right.
I'll speak for myself anyway.
Cool. Well, thank you again, Alex. That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.